What we're doing is your body's gone through this transition and we're just simply replacing, right? What may be beneficial and helpful for symptom relief. We're not looking at giving you doses that are high enough to get you back to being 25 years old.
I'm going to tell people the 5 kinds of hormones that I am on so that you can unpack them.
Hi, I'm Dr. Vonda Wright, and this is Hot for Your Health. Join us for conversations on the bleeding edge of science, health, and culture as we bring you tech innovators, thought leaders, and the movers and shakers who are transforming science fiction into your new health reality.
So I'm so happy to be here today with 2 incredible experts and friends, Dr. Dombo and Dr. Menn, who are both in clinical practice. They also both happen to work with a company that I refer to a lot, Alloy Health. And so I thought today we would just talk about all the different scenarios I see in my clinic and then I often refer because so many women not only are confused, but if they're not confused, they're raising their hand and saying, but what about me? I have all these special circumstances. And I just think it's worth going through. So in a typical Tuesday and Thursday orthopedic clinic, because I am a whole person doctor, and someone comes in with the old frozen shoulder that doesn't move right, I move right into a discussion of perimenopause, which I think we should try to define what the heck that is. And should we be even making menopause hormone decisions in perimenopause? So I just want us to start way back because I am committed that the young millennials will not suffer like many of us did.
No, I completely agree with you, Dr. Vonda Wright, because we tend to see a lot of patients postmenopausal, menopausal, and perimenopausal, but I think we get a lot of questions from patients who are perimenopausal who are having symptoms, and they feel like they are either told, by their clinicians that, okay, well, you're still having a period, so, you can't be treated. We also get, women who are symptomatic, debilitating symptomatic. And we know that those fluctuations in hormones during the perimenopausal phase can result in debilitating symptoms. And, I always tell patients, like, you are the one to tell me, where you are in this, because just because you're perimenopausal does not mean that your symptoms aren't worth treating. So I can just start with, your first question where you asked, okay, what are the different stages?
Yeah.
What is it? So we know menopause has been defined by 12 months without a period. And we know that the time frame before that, average age in the United States is 51. The time frame leading up to that is what we define as perimenopause, right? This is a time where your ovaries start to have these intense fluctuations of hormones, right? Your brain is telling your ovaries, push out more estrogen because we're not seeing as much estrogen inside your system. So your brain is trying to get your ovaries to produce more because they're detecting lower levels. So this causes huge fluctuations, right? In either estrogen, progesterone, and symptoms, quite frankly, that are consistent with menopause because you have these dips that can cause significant symptoms. You also may notice like changes in your menstrual cycle. They become longer, between cycles, you can experience really heavy bleeding, or you may notice that your cycle length becomes shorter. So these are all changes that can occur, but just because they don't occur does not mean that you're not experiencing these fluctuations. So I think it's just really important to identify that. The symptoms during perimenopause, which can be 10 years, up to 10 years before the average age of menopause, can be debilitating and worth addressing. And, there are options, whether it's low-dose birth control pills or menopause hormone therapy.
Yeah, and what Dr. Dombo and I both see on the Alloy platform is it's a place where people initially come just because they're so confused and they're told wrong things. They're told things like you can't possibly be having menopausal symptoms yet because you still are having a period. A lot of the things that Kudzai just, alluded to. And so much of what we get on the platform is this initial, just like it's an education opportunity. And I think that's something that we really like delivering. And it's like something that we're really proud of. And because we're asynchronous and there is messaging back and forth, you don't have to wait 3 months to like get an answer to these questions. So much of what we do, especially on the front end, is just educating women who come with, these misconceptions, or they're kind of written off. And it doesn't mean that we're saying, yes, hormones for everybody, but people can come here and find, at least we're going to start with accurate information about perimenopause and menopause. And then we're going to get into obviously their history, and we can dive into all of the reasons why they're told no, they can't have hormones, when very often they can consider it as an option.
I think something that I didn't know until I got deep into this is something you just said is it's the delta in hormones. It's the up down that really drives our body crazy. Is that right?
Yeah. I mean, so again, it's the fluctuations that occur. And I think this is where the biggest misconception has occurred within the medical institution, because traditionally we have defined menopause as, no period for a year. Therefore, oh, we know you're in menopause, therefore we can treat you. But we have not been taught, we haven't, really identified as perimenopause being a time of great need. And so essentially what tends to happen is, again, we know that with time, the number of eggs in your ovaries, oocytes, declines, right? You're born with 1 to 2 million. And then by the time, you get to puberty, you may have 300 to 500,000. And then by the time you get to menopause, you're like at about under 1,000 oocytes. And so this gradual decline, the brain is like, wait a minute, why is there less circulating, hormone? So the brain just identifies that and starts to, like FSH is a hormone produced by the brain that targets the ovary to produce. And so the brain starts tapping the ovary and saying, hey, produce more, produce more. So we get these fluctuations because the ovary is kind of like, okay, I need to produce more, but then I'm not able to really produce more. So we get these spikes and dips and spikes and dips. And those spikes and dips, I mean, when you look at the statistics of women who go through, the highest incidences of depression, the highest incidences of, whether it's the mood symptoms, it doesn't have to be the hot flashes, but the mood symptoms that they encounter, as a result of these fluctuations, because we know that estradiol has an impact on the brain, right? It stabilizes serotonin, the feel-good hormones in the brain, the feel-good neurotransmitters. So when this fluctuation occurs, women start to feel like, I just don't feel like myself. Right. And because that I don't feel like myself has not quite been defined, in traditional medicine, like it's like, oh, well, if you don't feel like yourself, maybe it's stress, maybe like it's been so easy to dismiss. And we see that all the time. They all come to, like, a lot of them come to Alloy and say, I told my doctor this, I told my doctor that, and they told me this, just, go, maybe you just need to take an antidepressant. Maybe like we see it. And that's where, as Corinne said, or Dr. Menn said, it really takes educating women about what's going on in their bodies so that they can understand, wait, you're not going crazy. And there are solutions so that you can feel better.
Yeah, and this idea of this delta and the high spikes of estrogen, it's sometimes that contributes to the mood, having too much estrogen or having a really large spike. And so then people ask, well, then why are you giving hormone therapy? And I try to explain to patients that menopausal hormone therapy, HRT, whatever you want to call it, we're giving you very low, small doses so that it's like a buffer zone, I tell patients, so that yes, you're going to have some highs, and anytime you have that high of estrogen, that little amount of that estrogen patch that I'm giving you is not really adding that much to that, right? So that surge maybe in breast tenderness or whatever that's happening at that time, it's not being caused by your estrogen patch, right? But we're going to prevent you from bottoming out, right? We're giving you this low kind of steady state to give you some stability. But when you're having so many fluctuations, we never want to vilify the birth control pill. And again, this is another misconception out there, that women are also on the other end of the spectrum, are being now they're afraid to use birth control pills, which can be helpful in perimenopause, but they don't agree with everybody, and not everybody chooses them. And it's okay to say, here are both your options. Now, there are some people that were really going to say, listen, you're not a great candidate for menopausal hormone therapy yet. You need contraception. Your bleeding is out of control. We've got to really get those cycles. But for a lot of women, particularly in the later part of perimenopause, where bleeding and period issues are not their main problem. But a lot of powers that be tell women that no, while you still have your periods, it's silly. You birth control pill is the main like gold standard answer. And I actually don't believe that's the case. I think when we're dealing with needs of contraception and bleeding control, that's one thing. But even when people need that, we've actually all learned from each other, which is one other great thing in LA is that we're always consulting with each other. We have doctor office hours. We have difficult cases that we'll share with each other, and we've all learned what works beautifully sometimes is to give women a progestin only birth control pill, thins out their lining, prevents ovulation, helps, even out their periods. And then we give them back an estradiol patch so they can kind of have their cake and eat it too. So there's a lot of ways we can help you hormonally. And we never tell patients it's only hormones. We're always like, listen to people like Dr. Wright, who's talking about how you have to use all of the tools that you have and really care, because a patch isn't going to help build muscle if you're not lifting weights or you're not, moving your body.
Well, I like something you didn't say it directly, but you inferred it, is that this is really precision medicine at its best. There is
Yes.
no one size fits all, because one woman may respond to progesterone. One woman may need low dose. So when we talk about modern medicine and one size fitting everybody, or now we're entering the precision medicine stage, I think this is a beautiful example. And even why, dare I say it, you don't have to nod your head or blink your eyes, but dare I say it, that sometimes standard protocols just don't work because nobody fits. It's one size fits nobody.
No, but that's the art of medicine, right? Like all of us grew up in medical school and residency learning from the physicians who had been there, done that. They were older than us. We weren't learning just from a textbook. We were learning from clinicians who had clinical experience. And this is how we became good doctors, because we spent all those long hours following them, learning from them, right? And so when we kind of boil down menopause care to like a checkbox, or this is what the guidelines say that's not the art of medicine. And frankly, the broken healthcare system really is encouraging that type of medicine, because you have such short appointments and you may not be able to see your doctor for months to get into for a follow-up. So I think this is why we're all three of us, and a lot of the people, all our colleagues, we're trying to like be more creative and try to serve women in ways where we can actually deliver kind of that type of precision and individualized care, because the current state is not encouraging it. Let's face it. No.
One thing too, I'm sorry, just to what Corinne said, because I do think that with the vacuum, right, for the last 25 years, we haven't had women who are routinely on hormone therapy. So we do get a lot of patients who come in saying, oh, my girlfriend is on this. Why don't I need to be on? Like they look to other women. And it's again, reiterating and reassuring patients that, look, you are not your girlfriend, right? Your girlfriend may have had bleeding and you're having bleeding. So this is why I'm offering you a higher dose of progesterone than your girlfriend may be on. So when it comes to precision medicine, what I love about, just being one of the prescribing physicians at Alloy is that we really look at each person distinctly, individually. We look at their bleeding patterns. We look at like their symptoms. We look at their family history. And this is how we decide not only the dose that they're on, but the form of estradiol that they're on, whether it's a transdermal, that's a better option for them than an oral. But again, going to what you said, precision medicine, I think, again, we don't have guidelines, right, for, Black women, different, groups of women. But what we can do is look at each person individually and make a treatment plan that caters to them and what their clinical scenario is.
I love that. And I hope people that are listening realize that everyone is their own person and everyone gets to choose, right? everyone is sentient and gets to choose. And what I've chosen to do, and I'm going to tell people the 5 kinds of hormones that I am on so that you can unpack them and why I might be on these. And so I take estradiol, body identical, and you can explain what that means to people, transdermally, systemically. This treats all of me, right? With that, because I have a uterus, I take 100 milligrams of micronized progesterone nightly, and it helps me sleep, such that if I forget to take it, I get out of bed to go take it and put it in. So that's 2, right? Number 3, years before M4 and M4 eye cream were available, I was sneaking some estrogen onto my face because I started this so long ago. I had to call the secret doctor in Chicago to get some compounded estrogen. And I'm thinking, why am I putting this on my belly? Why not put a titch of it on my face? And then I read the dermatology research that, oh yeah, localized doses. So that's number 3, right? I put estriol on my face. Number 4, to prevent the genitourinary syndrome of menopause, I'm all about vaginal estrogen. And then number 5, I have chosen to up my game, turn the lights back on with some testosterone. So you can unpack that any way you want, but there are a lot of opportunities to, in my opinion, give my body everything I had when I was a much younger woman.
Yeah. Well, I can start with that, and Corinne, you can also jump in. But what I love is that, like with the systemic estradiol, what I try to tell patients when they go through the transition, we're not looking at giving you doses that are high enough to get you back to being 25 years old. What we're doing is your body's gone through this transition, and we're just simply replacing, right? What may be beneficial and helpful for symptom relief. And we start with bioidentical, body identical, essentially is the term that you used, because body identical really means just the specific structure. Yeah, it's, estradiol. And that's the same structure that your ovaries produce. So we are really looking at replacing enough to give you symptomatic relief, what your body was already naturally producing, right? And so then that's the one thing, and that's that helps with the systemic symptoms, like again, if you're having any night sweats, if you're having irritability, mood symptoms, joint pain, palpitations, just symptoms that are associated with estrogen deficiency.
But even I have to sneak in loss of bone. There is no question amongst all the debate that our body needs estrogen to prevent loss of bone. So,
and Vonda, and that is so important because some people will say, well, what about the woman who doesn't have really significant symptoms? She's not dealing with a lot of vasomotor symptoms. Should you still prescribe hormone therapy to them? And what's really interesting, if you really look at what the guidelines, the Menopause Society guidelines, and a lot of the language that's been used, really more recently, it's softened a bit, but it's always been like, for bone protection in a symptomatic menopausal woman, you should use hormone therapy. But then they always jump in but if they're not symptomatic, consider other non-hormonal, quote unquote, safer things, which is, kind of this, I think this old adage from the fears because of the black box label, etc. But, make no mistake, the safest, most effective really option for preventing bone loss is estrogen in some form, whether it's bioidentical estradiol or another form of estrogen. We've got different, choices out there, but that is really the gold standard. And it's why when we have a premature loss of ovarian function, someone gets their ovaries out early, it is honestly medical malpractice to not give them back full estrogen replacement because of the very significant loss of bone, for one, and then there's other things as well. But I often feel that bone discussion often gets lost in the shuffle as a really important reason. And we have to remember the FDA rarely approves a drug for prevention. Because why? Because that means you're saying to the population, this drug is so good that really anybody can take it for prevention, or not anybody, but well-selected patients should take it for prevention of disease. Most drugs are designed for treatment of a medical problem. This is prevention. And so this is not even controversial. Like, this has been approved for the prevention of osteoporosis for decades. So yeah, hormone therapy is preventative medicine. And anybody who says it's not is, I think, conflating some of the lack of data on the final word on dementia or cardiovascular disease and conflating it to, say, oh, it shouldn't, HRT is not for prevention. Well, yeah, it is. And bone loss is a major, problem in our country. So
Oh,
why wouldn't
it's
we
an
want more people
epidemic.
to?
That's right.
It's a huge epidemic. If we just cared about it, even from a cost standpoint, didn't you publish,
I did.
Dr. Wright?
Yeah,
Yeah.
a cost savings. It's
I mean, I think that's an important point.
billions of dollars. Yes.
And let's talk about the cardiovascular, right? Because we know that if it started early enough, like estrogen has been shown to cause the arteries to be more flexible as you age in the absence of estradiol produced by your own ovaries. So I really do think that, I'm talking to the demographic of women who are either in premature ovarian insufficiency, or early menopause. Like, I'm looking at those women who they have been shown to have substantial risk when it comes to the cardiovascular aspect. So I think it's very important to identify that. It has been demonstrated in those women, premature ovarian insufficiency, that it puts them at a negative or a disadvantage when it comes to cardiovascular risks.
Well, and that's how I frame hormone optimization or estradiol replacement is preventative. I mean, at least, the orthopod in the room, there is no debate, people. So everybody can argue about brain and heart, but there is no debate. So, okay, some form of estrogen. I have a uterus, micronized progesterone, right? Any comments about that? You can't get away from it, right? You can't not do it.
Well, I mean, one of the common things that we see, and this is why I think this is really important, because Dr. Dombo mentioned the vacuum of care. So there's a lot of people who are denied hormone therapy by their, say, regular doctor, their PCP or their GYN. So then they go to this vacuum and they find some other clinician who doesn't really know what they're doing or is selling them things that they really shouldn't be on, like progesterone creams for, as part of their hormone therapy. We see this actually a lot because they've had other providers put them on that. So I'm so glad to know you're taking oral micronized
Yes,
FDA
I
approved
am.
progesterone, because we know progesterone is a really large molecule and it doesn't get well absorbed via the skin. So you have to take it orally. And if you don't like oral progesterone, which some people, maybe about 10%, feel too sleepy on it or they have GI upset, etc., we do have safe synthetic progestins that are FDA approved that we can use and we should not vilify. But a lot of what we do also at Alloy is pick up the pieces of people who actually get hormones from other people, but they're being given, honestly, things that they don't need. They're not necessarily safe, or they think that they have to get special compounded systemic hormones if they want body identical or bioidentical. And the reality is most of the hormone therapy that is FDA approved is bioidentical. But I don't like when people say, oh, it's only a marketing term, so we shouldn't say that. There's some people who like to complain about people using it. I think women have a right to know that this hormone is body identical from a chemical form. It doesn't mean that it's magically picked off a tree. It's all made in a lab. We have to, we're honest with it. So it's not natural in that it's just appears. Yes, it's made synthetically in a lab, but its chemical structure is the same. And it's okay to tell women that.
It's the same
And it's
molecule.
also, yeah, and also it's okay to tell them that there are synthetic versions that are FDA approved and safe that might be good choices for you too. But I think it's okay to use the word bioidentical and to kind of tell them that you don't need a special compounded systemic compounded hormone therapy, if you want bioidentical. And we do see a lot of people coming on these progesterone creams. It just doesn't protect your uterus enough. So
Well, and I've had a couple really young women, young 41. One wrote me the other day, 41, because people tend to write into me. I can't be your doctor if you write into me. You can write into me, but I cannot be your doctor. Telling me that she was feeling awful, and her doctor started her on micronized progesterone. I is that a thing?
in perimenopause, it
In
is, yeah.
perimenopause, right? Yeah. So, okay, so that's those two. And then,
And I just want to say for anybody listening to that, why does that matter? Because this is, again, something that I feel like is really underused and can be so safe, so helpful for women. You know, Dr. Dumbo was explaining this big surge, this up and down, and sometimes very irregular menstrual cycles in perimenopause. What is happening there? You are not ovulating. When you go 3 months without a period and then suddenly you have a period, you are not ovulating, right? And so we know that if you don't have a period, it's a sign that you didn't ovulate and go through that cycle. And so when you don't ovulate, you don't make progesterone. And what does progesterone do in a really simplistic way? It's a calming hormone in your brain, helps with sleep, helps with anxiety. It dilates blood vessels. It also protects the lining of the uterus, of course. But what is the most common symptom we see in women in perimenopause? New onset of insomnia and anxiety. Sometimes they're not even ready. They don't even need estrogen yet because they're having these big fluctuations. You give them a nightly dose of progesterone. Sometimes we cycle it. It can do wonders for a number of years. And then we can add in low doses of that kind of buffer level of estrogen that we were talking about.
so then two kinds of local, not systemic estrogen application, M4 and vaginal estrogen. Let's touch on those because it sounds like a laundry list, but it's really specific. There's a reason for each one of these.
Yeah. Well, I can share specifically looking at vaginal estrogen and, also the M4. I think it's important to identify because I didn't know this, right? As an OBGYN, how the impact of loss of collagen in your face starts during perimenopause, when you start to have those hormonal fluctuations. And then, it gradually declines like throughout menopause. But I think what tends to happen is we start seeing the changes in our faces. We start seeing, once we, go through menopause, and that's where we want to start. But what is really important is that I like to, inform patients or at least tell patients that when you are in perimenopause, that is the time when you are experiencing, and we just talked about bone loss, that is when we need to start making those changes in order to preserve, right? Not only our bones, but then also like the collagen in our skin. And so, just as you said, estrogen has those properties where it will help boost collagen within the skin. And it also does the same thing in the vagina. There are vaginal estrogen receptors vaginally. And so we know that when you start having changes vaginally, like, okay, I'm starting to notice urinary symptoms. I can't make it to the bathroom, or I'm having recurrent UTIs. And this is new for me. Or, I'm just having this discomfort during sex. Like we know that estrogen has an impact, in the tissues, not only in the face, but also in the vagina. So knowing that, adding topical vaginal estrogen, right? It literally acts on the tissue, has not been shown to be absorbed systemically in significant amounts. So being able to address those changes, I found that it has drastically changed the lives of women when it comes to their marriages, when it comes to, just quality of life, like not feeling like they're going to run to the bathroom and leak on the way there. Like I have heard it from patients, and it's something that is one of the most simplest, things that you could do, safest things that you could do. So vaginal estrogen is significantly, it helps significantly with the vaginal symptoms that come or as a result of the changes.
Such low hanging fruit, right? And like this suffering when we tell women that you might just have some vaginal dryness, and then they're not informed, they don't understand why they're having what you just mentioned, the running to the bathroom or decreased arousal, sex doesn't feel as good, orgasms are harder, right? Because thinning of all the tissues, right? Not just vaginal dryness. It's that vulva, it's the clitoris, it's the urethra. It's not as robust, that tissue. So little bacteria get up. So just like informing women that this is actually physiologically what is happening, then allows them to make a choice, right? But when you tell them just use some lube, this is normal part of menopause, and we're ignoring suffering for no reason. And when another common reason why women come to LA is because they're told, well, I'll give you the patch, but you don't need vaginal estrogen too. It's too much estrogen. That's not scientifically based. It's not even guideline based. It's not, you're not doing double duty. One is local, one is systemic. And then the facial estrogen, some people want to make controversy over facial estrogen because we don't have an FDA approved form. That's okay to tell women that, right? It's important. We acknowledge we've got great FDA approved options for systemic hormone therapy, and we've got great FDA approved options for vaginal hormones. But unfortunately, because of the black box label and the lack of training, over the past 20 years, there was very little interest in developing new hormone related products. Nobody was touching it with a 10-foot pole. There was just zero interest in it. Mm-hmm. So the only reason that a drug company doesn't have some form of facial vaginal estrogen is because of fear of that black box label. And so no one stepped up to the plate to do it. There was no money in it, right? And so should we tell women that we know topical hormones help skin because we've got decades of data on skin of the vulva, right? We know this. And in the dermatology literature, there's not large clinical studies. Like, we can be honest, women, there's small studies, but they all point in the same direction. And we have large studies of vaginal skin and vulvar skin, which is not actually that different from your facial skin. There are some differences. And so we can be honest and say, we have then chosen to develop safely. This is a compounded product, and it's estriol. And we chose at Alloy to use estriol versus estradiol for a couple of reasons. There was a few small studies that showed that it was equally effective in the skin. People don't know this, but in Europe, the FDA-approved version of vaginal hormones in Europe is estriol. They probably chose that because it is a less potent estrogen. Even if it was systemically absorbed, it has very, very weak power of binding to the receptors in the uterus and the breast. So from a safety standpoint, all things being equal, considering we don't have an FDA-approved version, we're like, let's go with estriol. It's a weaker estrogen systemically. And let's do it in a same percentage as what is they use as standard of care in Europe for vulvar and vaginal use. And the same percentage is supported in the literature. And then we went a step further and we said, if we're going to offer this, we're going to study it. And so we've done multiple studies and making sure that it's not adding to your systemic load, right, of estrogen. So estriol, people don't realize this, it can't convert to estradiol. You can't change estriol into estradiol. But we measured estriol and we measured estradiol just to be sure at baseline and at multiple points over a number of months, and showed efficacy, but also really importantly showed safety, right? Do we want more studies? Yes. Would we love to see big studies of this? Sure. Do I think it's going to happen? No. So I think our responsibility as doctors to patients is to say, like, here's an option. This is the safety data. Here's the data. You are a sentient being. You can choose to use this if you like. And that's the choice we're giving people.
Well, and I choose, because you know what, I pressed on one of these on Instagram, and now my whole Instagram is taken over by women with phenol peels on their face. I mean, women are choosing to peel off all their skin with phenol, right? That's a choice. You can do that. Or it's your choice. I choose to use what my body uses to help my plumping of my collagen. Because before I started sneaking my estradiol, my cream onto my face, I did look up the dermatology literature.
Yes.
And I did query my dermatology friends. And I'm like, did you ever hear of this? And they're like, oh yeah, people do this. We just don't talk about it. So Okay. We've worked through 4 of my 5. Somebody comment, even though there are difficulties prescribing it, somebody comment on testosterone, how we feel about it, where it comes from, because then I want to get into a couple of the really nuanced cases before, in our last 14 minutes or so.
So I'll just say, so testosterone, and Dr. Dombo and I, we both are, involved in the International Society for the Study of Women's Sexual Health, ISHWISH. They've got an incredible global position statement on the safe, appropriate use of testosterone, particularly for low libido. And so I like to tell women that testosterone for low libido, we've got really good data on it, and it's a great option. And it's okay to tell women that, yes, clinically, we often see other benefits. There's a lot of mixed data on other benefits, but I always think that women are intelligent enough to understand that here's our kind of guideline supported data. Okay. Low desire. And also there's data support sexual response and can improve orgasmic function as well, because there's a lot of androgen receptors in the vulva and the vagina and the clitoris. And we can also tell women that we need more data. There's some data that suggests it may be helpful with literally a gazillion other things, because testosterone receptors are throughout our body. It's still a controlled substance. There's not an FDA approved version for women, and every state has a different guideline on how to legally prescribe a controlled substance. And there's specific telehealth rules about prescribing a controlled substance and then having to see that patient in person within a few months. So because of those limitations, we are not prescribing testosterone on the Alloy platform now. When people are looking for it, what I tell them is, I'm going to help you with these hormones, and I'm going to give you, here's the guidelines, here's the practice pearl, your primary care prescriber, here's how they can do it. I set it up on a silver platter for them. And I say, hopefully one day we'll figure out a way to be able to legally and safely prescribe you it. But I think we support its use. I use it myself. And I just direct people to the ISHWISH global position statement that is free, and anybody can Google it online.
And I think this is a great place.
And not pellets. We're not big fans of pellets because it's just hard. I don't want to vilify someone who feels good on pellets, but I want them to understand that you are just at risk of having much higher levels, and you could get side effects that won't go away. So why do that when you can use a safe transdermal gel or cream?
And I think this is a good place to insert that nothing that we've just described, estradiol, progesterone, or testosterone, are sex hormones. They are hormones, right? I mean,
body hormones.
Body hormones like thyroid hormone or any other growth hormone you produce. So, people raise their eyebrows because they think that, oh my God, testosterone's a man's hormone. Why would you even suggest it? And so just to clarify, anybody who hasn't heard me say it 900 times, they're just hormones, right? They work everywhere.
If we know, Dr. Wright, if we know that we are going to experience a decline, right, in estradiol and progesterone, testosterone is another hormone that the ovary produces. So to me, it's kind of like, okay, well, it's worth having a conversation about it.
Yeah, and just women who've had their ovaries removed, I always want to shout out to these women, because when you have your ovaries removed prematurely or even at the age past menopause, a postmenopausal ovary still makes testosterone. And so when you remove it, you're dropping your testosterone levels probably by about half. And so particularly for those women with any type of, removal of ovaries, I think it's a conversation they should be informed of. I think that's important, and that we can say it doesn't drop off a cliff like in menopause the way estrogen does. But recently, Dr. Davis, Sue Davis, the acclaimed testosterone researcher, kind of showed exactly what we are constantly saying, is that by age 40, that's when you see the decline. It doesn't jump off a cliff, but yeah, women in their 40s and 50s, they slowly have this decline down, and it doesn't drop off in menopause like a cliff, but it is a slow decline down, just like in men. And we help the men out we should be also helping the women out. But hopefully maybe the FDA will do something for
We
us.
help the men out on billboards, for God's sake. I mean, please. I mean, I order testosterone levels on men all the time when they come in with low energy and tendons popping all over the place. Just automatically. I feel like, that practice, and I do on women too because of the way I practice, but I just feel like that practice should become more commonplace. But if we return back to my practice and thinking about the women who walk in my door, I'm always bringing up these conversations. And for women in their 50s, I often say, have you ever been offered hormone optimization, or whatever I call it that day, hormone replacement, menopause hormone therapy, hormone optimization? And some of them will say, no, I have never ever been spoken to about it, which I think is a travesty and not. But many of them, without skipping a beat, I say, have you ever been offered? And they say, oh my God, that's going to give me cancer. And so my people have heard me talk about this a lot, but let's just talk about this again, about this reaction that will take a long time to get over. That women just have learned somewhere. They don't know a thing about menopause, but they know that line.
Yeah, I mean, I think this is what I live and breathe as a breast cancer survivor, and then seeing women who are at higher risk of breast cancer and just the average woman. I mean, like this is the biggest barrier to care, because old habits die hard. Those gut feelings of fear, die hard. We all know someone who is living with breast cancer who's been diagnosed because it's the most common cancer in women as they age, right? And unfortunately, it's happening to younger and younger women. And we know that it's not the systemic hormone therapy they're on, because only like 4% of women are on hormone therapy, right? So, so that's not really accounting for the uptick in breast cancers, which I truly believe is a combination of factors, very strongly, nutritional, lifestyle, alcohol, sedentary life, a really like a poor environment that leads to a lot of inflammation. We have to remind patients that when you say that something causes cancer, you're basically saying that it's a carcinogen, that it's taking normal cells and making them abnormal. And so we know that estrogen is not a carcinogen. It doesn't take a normal, healthy cell and mutate it and make it become cancerous, right? We have no data ever. There's no data on earth that shows that it's carcinogenic, right? So, these all comes back to the Women's Health Initiative and the very poor messaging, which, people can go about. They could read Estrogen Matters. They can go learn about it. We talk about it all the time. But the bottom line is the message that went out was not the actual data on estrogen. And actually, women who took estrogen alone had a lower risk of breast cancer, particularly conjugated equine estrogen. But subsequent studies, not as big, but other studies have shown that, yes, estradiol alone trends that way. The synthetic progestin showed a slight increased risk that was not statistically significant, but was reported to be. But let's take it at face value, I tell women. It was less than one. So it was a 0.8 extra diagnosed case of breast cancer for every 1,000 women taking combined hormone therapy. And that did not translate into increased breast cancer mortality.
Right.
And subsequently, we believe that it was largely driven by medroxyprogesterone acetate, which is a bit more inflammatory. It does increase breast density more than other progestins. And when you increase breast density, there's more numbers of cells, right? So there's more opportunity, right, for cells to, spontaneously mutate or because of other factors. But it's not estrogen that is causing their breast cancer. And then the last thing I want to say on this is everybody knows someone who has had estrogen receptor positive breast cancer, and then it is treated with estrogen blockers or things like ovarian suppression. So people say, well, if you're treating the cancer with an estrogen blocker, estrogen must have caused it. What they miss on informing women is that all breast cells have estrogen receptors. Yours does, Mine doesn't because I don't have breasts anymore because I had a mastectomy. But anyways, but my point is that I can make jokes about it because it's been 24 years. But, all cells have estrogen receptors on it. And so if your breast cells become cancerous, 80% of the time, they're going to keep the receptors. And part of the mutation in the breast cell is that the cancer actually manipulates the receptors and overexpresses them, basically uses the body against itself, right? That's very, very different from saying that estrogen caused it. And so while we use estrogen blockers as a tool to control aberrant cells, right? We use other tools. We try to kill it with chemotherapy, burn it with radiation, cut it out with surgery. Just the fact that those cancer cells still express the estrogen receptors doesn't mean estrogen caused it. Just like women who have triple negative breast cancer, those breast cancer cells actually are so abnormal and so aggressive that they've lost their estrogen receptor. So we can't use manipulation of the hormones. And we don't tell men who have prostate cancer,
Right.
which is very sensitive to testosterone. We do not tell them that testosterone caused their prostate cancer. Have you ever heard anybody tell it or men
No.
thinking oh my goodness, testosterone caused my prostate cancer? No. And in fact, we do treat them by withholding testosterone in many cases, not all. And once they're done with treatment,
They
with
can
shared
have it.
decision making,
Yeah.
those men sometimes, again, not all, sometimes can give back testosterone. I'm not saying that all estrogen receptor positive patients should be given back hormone therapy. That's a totally separate discussion.
Yep.
But to make women fear a hormone that their body produces,
Yes.
based on a poorly messaged study and a total misinterpretation of breast cancer behavior and what it is really sad. And then, there's actually someone, I did a podcast with someone else, and it's on my page today, where her sister had breast cancer 7 months after starting hormone therapy.
I saw
And then the
that.
doctor told her, well, the HRT caused that breast cancer. And I say that's not biologically plausible, because I want women to understand cancers take years to become clinically significant and grow. So, you don't give HRT and then tomorrow it's a carcinogen and it suddenly turns cells into cancer. And then 7 months later you have a mass. That cancer was there and it just happened to show up then. Right. And so this language of fear, I call lazy medicine, because it's just easier to tell women that than actually explain what I just explained. Right. And, women even avoid vaginal hormones. Women who have recurrent UTIs because they think it's going to cause them breast cancer.
Yeah.
Like our mothers will avoid it, or older women who would benefit from it, all out of fear. It's really sad.
Completely fear-based. Yeah.
Yeah, it's important to notice that the fear was also with us doctors. I did my residency in
Yes.
2001, 2005, and that fear was instilled within me.
Oh, me
and
too.
I did not offer hormones for the first decade of my, career. So I think it's important that it's not even just in patients, but it's also in clinicians, which is why we are where we are today.
And I think you would all agree, because I know you will agree, but even if we didn't know each other quite so well, none of us are saying that hormones are the magic bullet without the other lifestyle, nutrition, sleep, stress management that are critical ways to manage midlife and beyond. I don't want people just to assume if you decide not to, like 96% of all people, that, or, honestly, that's the data, unfortunately. If you choose not to or cannot, that there is no hope for you, right?
Yeah.
No, absolutely. And it's, and I think it's a large part of actually what we do as doctors, what I do on the Ally platform. We have all this content, all these webinars, all these experts like you who we give our patients access to, and we're constantly informing them this you can't outpatch a crappy diet. You have to pick up the weights and not the mamby-pamby pink ones, as Dr. Wright loves to say. It's my favorite thing. But I think about I often use the orthopedic analogy when I'm talking to patients about this. I say, if you have, say, a bad knee, And my father-in-law has really bad knees because he was a marathon runner. And his doctors have given him a number of choices through the years. He's very stubborn and he really should have probably had a knee replacement at some point, but he didn't. And so he managed it with modified his activities, with different types of exercise. He's had cortisone shots. He's managed the changes of aging with choice.
Yes.
Now, so like, and it's not wrong that he chose this. He didn't want surgery. He is still an active man. And, people make choices, right? You can choose to have glasses, contacts, or have laser, surgery. You have a choice on that aging, right? We have choice for lots of parts of aging, but so some people want to do these things. Other people don't want to do that. That's cool. But you don't want to do that. That's fine. But you should have a choice, right? And it's so sexist to me to think that like it's like somehow unnatural for a woman to not have a choice to, make herself feel better and like support bone loss by giving her something that's been FDA approved for more than almost 3 decades. It's like just weird.
Yeah.
And you know what? I think that sometimes it's called patriarchy, people, but I almost feel I almost feel like sometimes women are culpable too. I don't want to just say it's this evil world of male doctors. I think women are culpable too, and we just all need to be better educated, better advocates, so that there's no question when you understand some of the data.
Yeah, and everything in life is, risks and benefits and choices. And so if you don't want to, you know, treat your hot flashes and night sweats, well, you can choose to have disrupted sleep and all of the consequences and risks that come with that. You can choose to use an antidepressant. It helps some people with their hot flashes, or if that is your choice because you can't use systemic hormone therapy, there are non-hormonal medications. You have choices and options, but there's trade-offs to all of those options too. And we have to just be honest with ourselves about that.
That's right.
I think it's all education and all giving women the option to choose. That's the power.
Something as we're closing here, something I really like about Alloy Health is, I say this all the time to patients. I'm like, and get this, you get real doctors and you can text them anytime you want because it's asynchronous, meaning you don't have to show up for a long discourse, park the car somewhere, It's like, I'm going to text my doctor today and see and she'll get back to me in a few hours. And I mean, I really appreciate that for busy people. So it's kind of non-medical, but convenience wise, we're all busy people, for God's sake.
And also there's a lot of care deserts, right? Like we see people, Kudzai and I have spoken about it. It's really it's interesting. It's like very heartwarming and very rewarding. Like I see a patient who is like literally in a mountain town in Idaho, right? As well as someone who is in the middle of like New York City, and getting into a doctor is like getting into the best restaurant in like New York. It's like takes forever. You've, wait list and months and months and months. And so there's and then down south where there's like, all the OBGYNs are leaving because of restrictive women's healthcare laws and other factors. And there is literally not an OBGYN for literally 50 miles of them. And if they find them, they're only doing OB and they're not doing GYN or whatever, so we're reaching people who have lack of access to care for very different reasons. And they're like, oh my gosh, you are a lifeline for me. And I'm not having to then go to some weird other clinician who doesn't know what they're doing or just not get care, right? You see it all the time, right, Dr. Dombo?
Yeah. And I mean, I also see women who are like, well, I want to see a Black menopause expert, and so being able to offer them that because, being licensed in so many states, we can offer, okay, like there may be a little bit more conversation that's needed to establish trust, right? But we
mention
do
the support group and why
yeah.
it's like an interesting
And,
aspect. I think that's important.
yeah. And so what I do is I co-lead these Black women's wellness support groups, and they're open to everyone. And we basically have a space where we sit down and, we have women who come every single, time we have them. And we do them twice a month on Zoom virtually. But the goal is for these women to experience a sense of community, because there are a lot of women who come in and they're like, well, I don't want to do hormones. I've tried gabapentin. I've tried Veoza. and I'm still not sleeping. And so then we'll have somebody else in the group who says, girl, you have got to try. Yes. They'll be like, we've got to try progesterone. And then you know what? That patient will be like, you know what? My reason for not wanting to start hormones was risk for breast cancer. When we can demolish that, false belief, she comes back the next week saying, I'm on hormones. And it's really fulfilling because there's that support. It's almost like a village, of women who are like, we're here to support you where you are. And I can share my story to be able to help you. So there's a level of like deep trust.
Oh my gosh.
Well, we have to recognize there's populations of women. Black women is one example where there is not a great deal of trust in particularly women's health, and Black women's symptoms can start earlier. They can last longer because they start earlier. They're even more dismissed. They're like, you're too young for this. They're more likely to have their uterus removed, maybe keep their ovaries so they don't have the telltale signs of bleeding. There's so many reasons why some populations have even harder access, and a lot of maybe cultural fears and silence about the suffering that they've had. So again, because of the way we've kind of harnessed technology, we can offer support across large distances and bring people together in where we couldn't do that in a traditional sense. And because we really care about our OBGYN colleagues and our PCP colleagues out there who we know are working hard in a really broken system, I always want to send the message, we are not replacing these hardworking, amazing primary care doctors who were on the ground. We are trying to make their job easier so they can take care of what they need to take care of, because it's really hard to provide this type of menopause care in a way that is really kind of sustainable in the traditional model, right? So I think we want to always emphasize that we're collaborating, we're partnering, we're not replacing, we're just helping outsource this one aspect of care so that your doctor can continue to do what they need to do for you, right?
Yeah. And the patients are so happy when they can reach out to us. I mean, I'll have one who messages me every day, just because, she's like, oh, I had a hot flash, or, but they love that they can access somebody about symptoms or side effects or questions, or I had a spot of bleeding and I'm concerned. They love that they can actually reach out and get a response within a short period of time and not necessarily have to wait for an appointment.
Yeah, I love that too. It's so convenient. So doctors, I'm so glad to call you friends and experts that I refer to all the time. Thank you for being with us again, and I know I'll see you soon. Thanks for being here with us.
Thanks for having us.
My pleasure.
Thanks for joining us on Hot for Your Health, where we bring you conversations from the bleeding edge of science, health, and culture. You can find links from today's show and connect with me at drvondawright.com. Don't forget to subscribe and leave a review wherever you listen to podcasts. I'm Dr. Vonda Wright. See you next week.